Good afternoon. Joining us today for Aspire webinar series, webinar operating across the community to be very interactive, so we're anticipating that you will be highly engaged in today's session. We encourage you to ask questions and share information throughout the webinar today utilizing the question and chat panel. We will keep all lines muted to cut down on feedback, distractions, and echoing. Before we get to today's session, all lines are currently muted and in listen-only mode. Please chat in with your colleagues and hosts and panelists throughout the webinar today utilizing the chat panel. You can find it by clicking on the chat bubble on the lower bottom center left of your control panel. Please make sure your to setting is set to all panelists and attendees. This session is being recorded and will be made available on the NC Quality Center website and through email notification shortly after the conclusion of today's session. Facilitating for today is Trish Vandersee, Program Director of the Quality and Clinical Performance Improvement of the NC Healthcare Association. And presenting for you today is Dr. Amy Boutwell. At this time, I would like to turn the presentation over to Trish.
Good afternoon, everyone. Thank you for joining us for Webinar 4. We're excited today to talk through collaborating across the continuum. Dr. Boutwell will share with us today how to analyze patterns of pneumonia readmissions at your hospital, understand root causes of readmissions amongst your patients discharged with pneumonia, and help identify existing resources in your hospital as well as community that can be leveraged to reduce readmissions of your pneumonia patients. So I'm going to go ahead and turn it back over to Dr. Amy Boutwell. Reminder, feel free to chat and talk with us throughout the sessions. We love being able to answer your questions and have dialogue across our peers. So again, welcome Dr. Amy Boutwell.
Great, thanks so much, Trish, and great to be here, everybody. So today is webinar 4 in our Knockout Pneumonia Readmission series. As a reminder, this series is to support your work and your helping you achieve your aims to reduce pneumonia readmissions. We're really focused on connecting to your action, focusing on high leverage strategies to reduce readmissions specifically for pneumonia patients. And as we move through the series, we'll transition from content delivery and idea generation to implementation coaching. So as always, I would encourage you to pull up that chat box on your Zoom webinar platform, make sure you can find it. And just to get us started, if this is your first time joining the Knockout Pneumonia Readmission series, welcome, and it would be great time that would help us know if you've been with us for a while, and also we're always mindful of people who are joining us along the way. So as a reminder, hi Cynthia, great to have you here. As a reminder, we are basing our content in the Knockout Pneumonia Readmission Collaborative on the Aspire Guide, long form designing and delivering whole person transitional care. And it's been really exciting over the past couple of years to see how the strategic approach to that we developed in the Aspire framework is really resonating. And in particular, this driver diagram or this logic model that really unpacks that acronym ASPIRE. And as those of you who have been with us through the series will know, but just to catch everybody up, what you're looking at here is really the result of a I conducted for the for healthcare research and quality, but really of experience in readmission. Discern why are like they're doing the best they can there, right? That's just how. And thousands of hospitals and trying teams that are getting results, and who are in the right place and they're not getting results yet. Coming to the I study. What's the difference between that are working hard but not getting results? 2 gray boxes you see. So I don't want to skip over that. The 2 gray boxes you see are the differentiators to success. When I meet a readmission team and I program's all about, at that, whether or not that team is likely to be getting the results that they hope to get. And what I mean by that is the biggest differentiator for success is, do you have a data-informed design? Do you know what you're doing and why you're doing it? And is your program designed to address the root causes of readmission for your target population? And so we have really emphasized, we spent the first 3 webinars in our series talking about the 3 elements of the design bucket: analyzing your data, leveraging all that's already going on as far as it relates to transitional care, population health, accountable care bundles, and all of that in your communities, and then developing a multifaceted portfolio of strategies that helps to, you can draw a straight line between what you're doing and the expected outcomes. So that's all work that we've covered now in the first 3 webinars of our series. Gee, that sounds pretty logical. But what I want to point out is that many teams that are working hard and feeling like they're not yet getting their results, it's because they moved straight into deliver. They moved straight to solutions instead of designing those solutions to meet the needs of their specific patients in their specific communities, drawing upon the specific resources that you have to bear. And so have you done the work in the design bucket that we've now covered, and are well positioned to what we on? I know we're all focused on pneumonia, for a subpopulation of those patients. Causes of readmissions. Do we have a multifaceted portfolio of strategies that is designed not to do what we can do, but rather to meet the needs and address the root causes of pneumonia readmissions in our hospital? So that's the Aspire Guide, and that's the thinking behind it. So here we are, webinar 4, and we're going to be talking today, of course, about actively collaborating across the community. And so that's, you can see how that tracks along with various sections and tools in the Aspire Guide. Of course, reference and read the guide if you want, but that we're customizing but really the methods are non-disease specific in nature. As you can see, we're one more content webinar in the late summer, and then we'll come back after Labor Day, and I really, really, really hope to have at least a dozen of you here on the phone today and participating in well, a dozen or more, hopefully, ready to really engage and reflect and actively participate in a discussion that says, okay, we've heard the content, we know what we're doing, we've learned some lessons from the content, how can we use our in-person workshop together to really, because I'm here and I'm coming to North Carolina to help you achieve your aims. So the more you're able to process and knock out pneumonia readmission reduction work to enhance some advice so that you can really pick up the progress and achieve the aims that I know you are so committed to achieving. Okay, so objectives for today. Obviously, we're talking about cross-continuum collaboration, and I hope that at the end of this hour, you'll be able to identify, really, I'd like you to challenge yourself, 3 providers or agencies, meaning not necessarily clinical providers. Identify 3 providers or agencies of your high-risk pneumonia patient. Walls of your hospital, who is interacting with that pneumonia patient once they leave your building. Number 2, I'd like to inspire you and encourage you to develop working relationships, not just knowledge of, but working relationships with the providers or agencies that share in the care of your high-risk pneumonia patients so that you can build new processes to ensure that your high-risk patients are definitively and timely linked to the services they need at the point. And finally, I'd like you to really think about and recognize that the term refer to is quite passive. And no readmission reduction success story rests on the answer that we referred the patient to home care, we their pulmonologist, we referred the patient to smoking cessation. Success requires back and continuous success with which link patients to services, access services themselves. And so around cross-continuum collaboration, it's about senders and receivers actively collaborating so that we improve clinician to clinician processes, but we also circle back closed loops and make sure that we're minimizing the chances that patients fall through the cracks. Ultimately, today's message is reducing readmissions is not only about high quality inpatient medical care, it is interdisciplinary team sport. And I hope that you can come to see that reducing readmissions requires a team across the continuum that may or may not be paid, employed by your organization, but nonetheless, we need to build those functional relationships so that we can get the job done. So taking a quick pause, and I'd love you to chat in or engage with this content. This is the reminder of the design bucket that we just went through in the past 3 webinars. So I call this a data-informed approach to efforts, and it should answer the questions in the following order. What is our aim for pneumonia, reduce pneumonia readmissions by 10% by the end of the year? And what does our data and root cause analysis show? So, for example, you can see here in the chevron, data, our North Carolina data and your knockout pneumonia specific reports probably show you that pneumonia patients discharged to post-acute care have high readmission rates. I know from other data that pneumonia patients with behavioral health comorbidities are at higher risk of readmission. We can't get it from the data, but we know from our patient interviews that pneumonia patients who are at the end of life are at high risk of readmission unless their goals of care and supports are addressed. And so what we want to do is we want to marry what we see in the data with our patient interviews, and they go in the same box together. It's data and root cause analysis, just like it's displayed here on the screen. And then we want to say, why are our pneumonia patients coming back? Well, some people clearly have difficulty navigating. They're told to follow up. They run into barriers, calling the pulmonologist or the specialist or getting into pulmonary rehab, and there's a long wait, and they have a difficult time navigating the system. So what happens? It's not that they didn't try, it's that they give up. And a very human approach to navigating a complex system. And of course, we've discussed other more straightforward challenges like a lack of transportation or unclear goals of care, et cetera. So whatever your root causes are for your patients, you really want to focus on those and then ask the next question is, what we're learning about why our pneumonia patients actually do come back to our hospital. Then the next question is, how shall we target? Who should we target our efforts? Some of you, especially in smaller size hospitals, you might be focused on all pneumonia patients. Those at the larger hospitals, you might be focusing on a subgroup of pneumonia patients, like pneumonia patients being discharged to skilled nursing facilities, or pneumonia patients who screen positive on a palliative care screen, or who have aspiration risks. Okay, there even within pneumonia, there are ways to stratify the population. And so once you decide on, and our target population or populations are you focused on, what should we do? The interventions should flow from the answers of 1, 2, and 3. And the interventions we take should address the specific target population and the root causes that we know are driving those groups back into the hospital. You've heard me say this before, but I'll say it again. Most teams start with number 4. Say, well, we want to reduce pneumonia readmissions, so we're going to start making post-discharge calls. We're going to appointments for 7 days post-discharge. We're going to do teach back at the bedside. These are all fine things that might be part of a strong strategy, but I wouldn't be able to tell you that they're part of a strong strategy unless I know the answer to number 2, which is, are your patients coming back because they weren't able to have an appointment? So if you make an appointment for them, they will go and it will be, protective for them, right? You want to make sure that whatever you're doing is addressing the root causes. Okay, so I hope that you're all able to get to this point, at this point. This is a worksheet you to take this slide to your next Knockout Pneumonia team meeting and answer these questions. And in fact, I'd love you to chat in right now. Let's go quickly through these 4 questions. So, consider high risk of readmission. And again, some of you at small hospitals, you might say all pneumonia patients are high risk of readmission. And in fact, for our purposes in the Knockout Pneumonia campaign, we know that our pneumonia readmissions statewide, and that's what brings us together. So you would always be right in saying all of our pneumonia patients are high risk of readmission. So I'm looking at the chat, hoping that you're going to chat in. Some of you might say, well, we're focused on Medicare pneumonia readmissions. Or some of you might say we're focused on Medicare pneumonia readmissions that are being discharged to home. Or even better, Medicare pneumonia readmissions that are being discharged to SNF. So I don't see anyone brave enough yet to chat in. If you would, which pneumonia patients are you focused on? Now I put something here on the slide. It's provocative for a reason. I know that everybody's out there using LACE. And I don't want to take the time necessarily right now to go through LACE and the specific elements of LACE. But hopefully from our webinars on data and root causes so far, you have not heard me talk about LACE, and that's because I do not use it. I do not find it helpful. And if you want to know more about that, ask me and I'll be happy to dive into that in the future. What we have learned together, through patient interviews and your readmission interviews of your pneumonia patients is, gosh, if somebody is here with pneumonia and they have dementia, we can all look left, look right, that patient is going to be at high risk of readmission, right? We've all learned that aspiration is a specific subgroup that's going to require different teaching needs, goals of care, discuss obviously nutritional and speech recommendations, etc. We discharged with pneumonia to post-acute care services, whatever those services are, has much higher readmission rates, even though they're going into post-acute care. So we need to do something more for those groups. These are the types of risk stratifications that help you identify among all of your pneumonia patients who is high risk: dementia, aspiration, post-acute care, if they lack a care partner, if they have a behavioral health comorbidity, and you might know other risk features for your pneumonia patients. Thanks so much, Betsy. Betsy's saying if you have pneumonia and heart failure or ESRD, absolutely. And so that makes all the sense in the world for you, Betsy. Okay, so question number 2. What needs or challenges places them at high risk of readmission? And so a lot of people will say to me, well, our patients are non-adherent. from the data and root cause analysis webinar is we need to go a lot, well, not a lot deeper. We actually just need to go 1 or 2 levels deeper. That's all. When we go 1 or 2 levels deeper on the non-adherence topic and we ask, excuse me, why? We say, why? They didn't take their medications. Why? They didn't go to their appointment. Why? It's the answer to the why, either 1 why or 2 whys that get you to the root cause. So, so when you ask yourself, why, what needs or challenges place these pneumonia patients at high risk of readmission, we want to really get to the actionable problem that we can solve, which is they didn't take their medications because they had GI upset, or they didn't take their medications because after leaving the hospital, they felt fine. And so they thought they were all better. You know, whatever the case is, we can either address that problem with money or education or coaching or follow-up, you know, or something. But non-adherence is a hard one to fix. So you get my point. We want to go 1 or 2 levels deeper so we can get to a root cause that we can actually plan around and address. Number 3, what services, thus, would your high-risk patients need in order to address their needs? And so you say, well, the non-adherent patient, so-called non-adherent patient, they were readmitted because they didn't take their meds. They didn't take their meds because they couldn't afford their meds. They couldn't afford their meds, you know, because the antibiotics we ordered were had outrageous copays. You know, so we can address antibiotic selection, affordability, copay assistance in some cases, etc. So then we get to issues that we can start to address. Okay, and then finally, question number 4 is, who could address those needs besides us? Or how else could we get those needs met besides us? And so there's a whole world of providers in agencies outside of our hospital or healthcare system that potentially could be called upon to be part of the solution. Not, you know, nobody is a total solution. I mean, we're not the end all and be all for meeting our patients' needs, and so we can't expect that 1 or more partners in the community. Today, what we want to do is a portfolio of partnerships and get some more needs of our walls and when the admissions and get closer to. So you'll remember from last time we talked about the driver diagram, and I'm just going to refresh this again. I encourage you to take these tools back to your knockout pneumonia meetings and work with the 3 primary drivers that you see on this example and the next example. We're united by our commitment to reducing readmissions, and ask yourself, what are we doing in these 3 core strategic avenues? Number 1 is, what are we doing in hospital to improve the transitional care for our pneumonia patients while they're here? What are we doing to actively collaborate across the continuum, the subject of today? And then what enhanced services we need to offer if we really want to achieve our aim? So what you can see is, I'll call this a rather extensive, multifaceted portfolio, the likes of which I could imagine being applicable at a larger size hospital. And then this is a much more streamlined, but no less effective portfolio of strategies. Again, you can see something happens in the hospital at the point of cross-continuum collaboration and in delivering enhanced services. And it's actually a very process flow, the way this happens for the patient. And this is a real program that has really reduced actually pneumonia, heart failure, and COPD readmissions by 20%. So it doesn't need to be complicated in order to be effective, but what it does need to be is multifaceted. Okay, so collaborate across settings. Key messages. Collaboration is not just a handoff. It's a purposeful, measured, managed, collaborative, co-management relationship. whose job is it to foster cross-continuum collaboration? You know, it's very, some of you are specialists and some of you work in the intensive care unit and in other specialty areas. And, you know, it's natural when we're specialists in the hospital or hospital-based to think, well, we deliver care here. That's our job. We deliver high quality care while the patient is here. And what this incentive, what this market shift, what this delivery system transformation shift to high value care compels us to do is to broaden that thinking to say we need to give high quality care while the patient is here, and we need to ensure that the patient, at least for 30 days once they leave, so that they don't come back unnecessarily. And so that's the key point of this slide. And really, before hospitals are accustomed to doing this, it's hard to believe that agencies, you know, ranging from adult day health to behavioral health to county aging services or transportation services or faith-based communities or pharmacies, you might think to yourself, why would these people pick up the phone? Why would they agree to work with? Time and time again, the answer from these community-based agencies is always the same, which you see, of course, on the slide, which is, we would be thrilled if someone from the hospital called us. Of course, we would be happy to work with the hospital. And so don't let a perception of what's in it for them or why would they want to. Most often, 99% of the time, if you reach out to a post-acute community-based provider or agency, they will be more than thrilled to have your interest and attention. So I'm going to share with you 4 real-world practices around cross-continuum collaboration, and then 2 slides at the end to help you get started or help you build and evolve your cross-continuum collaboration if you are already underway. So I am very happy to say, and I don't know if we have anyone from Carolina's healthcare system now, I know it's named something different, on the line, but I'm very happy to say that in my 10 years of doing readmission reduction work and cross-continuum collaboration, one of the very best and most durable best practices was developed right here in North Carolina. You can see on the bottom of the slide, I'm indebted to a social worker named Emily Skinner, who I'm still connected to on LinkedIn. Don't know if you're on the line, Emily. And I learned about this at a poster presentation session for a care transitions meeting about 8 years ago now, maybe even longer. And Emily was charged back then to address SNF readmissions. The challenge was, it sure looks like we're getting a lot of readmissions, and think if a patient's going at less risk of readmission because they have those resources and that monitoring. Well, it turns out, as we know in our data, that SNF readmission rates are high. And so without going into the full evolution of this best practice, Emily developed a process that was not only a warm handoff, but the innovation was the circle back phone call. So a warm handoff, of course, occurs, and I'm sure nurse-to-nurse handoff for a patient going from a hospital to a skilled nursing facility. The innovation is the hospital calls the SNF back within a day or so, following 6 questions that you can see on the screen. For those of you on the phone only, I'll touch on a couple of them. Did the patient arrive safely? Is all the information in order? Are the medications correct? Does the patient look like you expected them to look? Is the patient and family satisfied with the transition? And important question number 6: have we provided you everything you need to provide excellent care to the patient? And I will tell you that this circle back practice has and when everybody in the audience gets to question number 6, they gasp. What a profound change. What a leadership moment that is for us in the hospital to ask our, quote, downstream provider right? Our quote vendor, our quote referral source. Have we done everything we need? Or have we done everything that you need to provide excellent care for the patient? So it's really showing that we are in a collaborative co-management relationship together. So I'm happy to say that in the spirit of spreading this practice from coast to coast and everywhere in between, a team in Virginia heard a webinar just like this about a year ago. And this woman, Joyce, who's on the right-hand side of this picture, Joyce, transitional care nurse at a hospital in Richmond, Virginia. She heard me talking about circle back. She got inspired by the questions and the simplicity of the model. She said, you know what, I'm going to give it a try. So she identified a point of contact at the skilled nursing facility across the street from her hospital, send a whole bunch of patients to, and she just started doing these circle back phone calls. And she was able to work it in. You know, it was part of her job as the transitional care nurse to make post-discharge calls anyway. So this was a natural extension, an obvious extension of her day-to-day job. So she started calling to the SNF, and this is what she said. Anytime I discover an issue, I always follow it up, right? So if the medication orders were unclear, if wound care orders were unclear, if there was something that needed to be clarified, Joyce would then be the one to turn back inward to her hospital and figure out who to route that question to, get an answer to the question, then she would follow up with the SNF, right? So that's obvious, straightforward workflow. When I started making these calls, I found issues 26% of the time, right? 1 out of every 4 phone calls, Joyce had to do something to follow up and clarify. After a few short months of doing this, it was after about 5 or 6 months of doing this, she only had issues 8% of the time. Makes sense because Joyce was the ambassador of higher quality transitional care. Every time Joyce comes to Dr. Boutwell and says, oh, gee, Dr. Boutwell, Mrs. Smith went to the SNF with Lasix 20, Lasix 40, which one did you mean? Then I'm going to learn to be better for the next patient. And so look at that. They slashed the need for clarification by, 300%. So very, very impressive and very impactful. Oh, I would be remiss if I didn't video Joyce and her counterpart at the SNF webinar and just getting started practicing and testing this new practice. So I really encourage you to do it. To practice number 2, the warm follow-up. So perhaps these are all going to be cousins of each other. So what this method is from another team, actually up here in Boston, is that they don't do call. What they do is they batch process it, which is also very clever. So what they do is on Fridays, they call 3 SNFs. They make 3 phone calls, the 3 high volume SNFs, and they basically, you will, touch base on all of the patients that went from the hospital to SNF A, to SNF B, and to SNF C that week. And so that, of course, as you can imagine, maybe somebody was discharged on Monday, but they discussed, of course, discharged on Wednesday, they discussed them on Friday. But what's nice about that is that the SNF knows the hospital is going to be calling on Friday. So if there's something that needs to be clarified that can wait until Friday, then they have a very time efficient and reliable process to say, I can wait until our standing meeting on Friday to get this question clarified. So they really like that process for that reason. So again, it's touching base on our shared patients. These are patients that went from our hospital to your SNF. Let's briefly go through them. Are there any issues for clarification? And the sender and the receiver now very happy. This is now a standard weekly call that's been going on for over a year, maybe even up to 3 years at this point. This is an old practice coming out of an AC. Key lessons: it takes a while to develop a warm, collegial, trusting, open clinical collaboration. This hospital will be the first to tell you that when they started calling Fridays, the SNFs on Fridays, the SNFs were very buttoned up. There were no questions. There were no points of clarification. Everything was hunky-dory. Why? Because of the classic referral-receiver relationship. The SNF didn't want to raise any issues or ruffle any feathers, right? And so the hospital knew we need to break down those walls. We need to demonstrate that we are good clinical partners, that we're not here to sunshine report. We really want to co-produce this outcome and be successful with readmissions. And so they took it even further, you know, to say, you have to give it some time to build the trusting relationship, and there's no substitute for verbal communication and collaborative problem solving. And so they modeled the change they wanted to see, which is say, well, look, you know, Mrs. Smith, we didn't really make progress with the goals of care conversation while she was here. We're wondering, do you think that you could pick that up and pursue that while she's there? And really to open up, not just say, no, but to really demonstrate we want to problem solve, we want to advance the care of Mrs. Smith while she's with you, etc. So the third practice, again, a cousin of the prior two, is then moving into longer-term co-management over time. This is what ACOs and bundles do. This is what we all do and what we will do and what we should ought to do when we're truly accountable for results. Meaning, pneumonia readmission rates down, then I recommend you think about some version of this for your program. So they have a dedicated point person that's a liaison with the SNFs, multiple SNFs, not one liaison per one SNF, but one liaison per a number of SNFs, again, according to your referral region and the volume, et cetera. And the idea is that that liaison, really this, I'm calling them a liaison because sometimes they're nurses, sometimes they're nurse practitioners. You know, the range is wide. Sometimes they're navigators of an unclear licensure, you know. And so really what's happening in this model is that the liaison actually physically or virtually rounds periodically on the patients, on the shared patients in this while they're in the SNF, and then picks up on the transition from SNF to home. And this is from an actual team. For example, the NP sees the patient weekly and touches base with the SNF staff. They are available to respond to changes in clinical status to help promote managing the issue in the SNF instead of sending this patient into the ED. They touch base via weekly telephonic rounds. They're talking about length of stay, progress towards discharge, and then transitional care transition. And so here's just generalizable practices that you might see potential for your program in any one of these bullets. I'll bring your attention to the last bullet because that's the lowest barrier to entry, where the hospital-based readmission team or transitional care staff case conference with SNF-based staff via phone on a weekly basis. And so again, that's where you maintain a list of all the patients that went to a SNF and work into your workflow a weekly phone call with your higher volume SNFs in order to touch base on a weekly basis until that patient goes from the SNF to the home, because as I hope you know, when they go from SNF to home, they are red flag alert, high risk to come back to you. And any of you who don't work in the emergency room and haven't been exposed to the story of mom was doing fine in the rehab, she got home and the wheels fell off the bus, and that's when 2 days later she's back in your emergency room. To your attention is to keep track of that patient across the entire 30 days, because your work is not done when we transition them from hospital to SNF. It's not even done when we manage them through that 10 or 14 or 20 day SNF stay. We still have 10 days left to manage. And it is classically the case that your SNF patients, when they go SNF to home, there's a very high bounce back rate at that point as well. Okay, practice number 4, ED treat and return. So sometimes we're doing all of these things and yet patient ends up back in our emergency room. Good news, all is not lost. We still have an opportunity to assess the patient, ask ourselves, does this patient truly need acute level of care, or can we evaluate, treat, and return the patient to a lower level of care? And so this is and there had been a statewide rollout of a readmission reduction program targeting the skilled nursing facilities. It's called Interact. I'm sure many of you have heard of it. And so the chief of emergency medicine at this one hospital got some feedback that said, you know what, chief, we are having a heck of a time achieving our SNF readmission goals because we're sending patients to you and forms that we are willing to take them back, but it's, once you have evaluated them, if they can continue their care back in the SNF, but that never happens. You never send anyone back. And so he said, I'm intrigued. Let me look at my data. And sure enough, he saw like 99.9% of all patients who come to his emergency room from a SNF were admitted, right? And he basically said, okay, I know that's probably not necessary. And he asked why 5 times. He said, the data shows we admit basically everybody who comes to us from a SNF. Why do you think that is? And he got all of the operating assumptions and some myths and misperceptions out on the table from his staff. Well, the patients are only seen once a month in that SNF, they can't do IV meds, or if the SNF sent them to us, it surely means that they can't take care of the patient, etc. But these are all direct quotes. And so he said, look, it turns out they can do more than you think. I won't bore you with the details because emergency medicine docs, they don't necessarily want to know the exact nursing home capabilities list for 5 or 6 SNFs in their region. That's not need to know information, but what was helpful to say, they can do more than you think. They can definitely do breathing treatments and IVs, and more importantly, they are willing to take the patient back if you think they don't really need to be admitted to the hospital. So my ask of you is, the next time you're evaluating a patient from a skilled nursing facility, just think twice. Could this patient be returned to the SNF and continue the treatment course that you have decided they need? Just think twice. That's all I ask. And so obviously he tracked that, and he tracked the number of SNF patients that ended up being discharged back to the SNF. And this is a 9-month run chart that you see. Simple. How many patients were sent from the ED back to the SNF? Month 1 through month 9. And this is what we want for all of you. And proof of concept, we are making practice change month in and month out. And of course, all of these SNF, ED to SNF transitions, this isn't a rigorous measure of a readmission per se, but everybody could agree this is a pretty great approximation of the number of hospitalizations, including readmissions, that were avoided based on this, quote, simple practice change. Okay, so that brings me to the new frontier of collaboration, is the emergency room. And I'd invite you to ask yourself, does your readmission reduction effort, does your knockout pneumonia campaign have an element that connects? We will do great inpatient transitional care, but sometimes people do come back to the emergency room. Sometimes they need to come back to the emergency room, but that doesn't always mean they need to be readmitted. And so do you have these 4 elements that comprise a strong strategy in the emergency room to help you with your readmission reduction goals? Do you have a flag on your ED tracker board to identify this person is a 30-day return? Do you have a care team that's notified if a high risk of readmission patient in some sort of transitional care or bundle or pop health program has just registered in the ED to allow them to get involved and facilitate a discharge? Do you have ED care alerts? that pop up to inform the new treating providers who don't know that patient that this is a knockout pneumonia patient, and they've already been enrolled in transitional care. Navigator's phone number. And do you have treat and return pathways, the likes of which can be as simple as the story I just told you? Hey, think twice. The SNF wants to take the patient back. Home health agency is willing to get a warm handoff from the ED. Can we get that patient back home? Can we move them from home to SNF, or can we get them back to the SNF? A quote here on the bottom of the slide is from a team I worked with in New York last year, and they were very enthused and motivated by the power and relevance of situating some readmission reduction work in the ED, saying in previous times the path would have been to simply admit the patient and we'll sort it out later. We're becoming more accustomed to working in the ER to help discharge patients from the ED, and that is a major culture change. So moving beyond the walls of our hospital into the continuum, these are questions for you and your team to think about. Do you have a relationship with a point person or agencies who serve your, because we're talking about knockout, a lot of our data comes from Medicare. Examples on this acute care, you have patients who be connected to and just in the limits of time, eased out a whole spectrum of collaboration that's natural and effective to foster with post-acute care, but definitely limits the imagination to the community-based providers and agencies that we need to reach out to as well. So regardless of who you're collaborating with, do you meet regularly with those stakeholders? Do you review data together? Do you review root causes and actual readmitted patient stories together to foster that trusting, collaborative collegiality? And after you do all that, I often meet teams that say, yep, we meet monthly, we talk about data, we do readmission root cause analyses, but that's where it stops. We can't stop there. You got to go all the way to number 5. What are you going to do together to improve our shared outcomes? You know, warm handoffs, case conferencing, transitional care from one setting to another and then to the next. We've got to take that effort you're putting into building relationships and establishing a shared understanding all the way into action. So that's part of what this Aspire tool number 12 was designed to really help with. And so this tool really presupposes that you want to build a new collaboration with a partner that you do not yet have a collegial working relationship with, or a regular working relationship with. And so obviously there's an entire section in the Aspire guide that provides some, but the key, let's imagine that for your pneumonia patients being discharged to home, you are really worried about your patients who lack caregiver support. And in your community, you know that there's a great spirit of volunteerism, especially through maybe some social volunteer organization, or maybe through faith-based communities. And you're wondering to yourself, well, I mean, I know anecdotally that, we have neighbors check on neighbors, and we have people driving, delivering meals, and we have people who are willing to drive people to appointments, but I don't really know how to set that up for my pneumonia patient who's in the hospital. Of course you don't. That one wouldn't expect that. And so how do you go about even structuring that exploratory relationship and then moving from asking the question to testing out a new process? And so that's what this Prepare, Ask, Test, Measure tool would help you walk through. So we'll just play this out. You say, you know, I know we have a very active set of congregations, for example, in our community. I'm not exactly sure what kind of volunteer programs they have. I'm not quite sure if they only serve members of their own community or if they serve community members in general. And so what should I do? So of course you've got to identify who to ask. So let's say you reach out to the three leaders of these faith-based communities. But and so that's the prepare. And then you want to ask them, of course, what do they deliver, and or what might they offer, what might they be interested in doing in a collaboration. And you want to be ready with your own data. And that's my key point here. Oftentimes we're focused on how busy we are and how many patients we are, and how many patients we have, that we perceive that there's no way a community organization can meet our patients' needs. And we kind of suffer from an all or nothing mentality when it comes to forming new partnerships, because we perceive that no one agency can meet the needs of all of our patients. I'd like to invite us to, break that down and say, having 2 or 3 or 5 or 10 patients better served per month is a whole lot better than 0. And so build it up as you go. So in this example, you meet with the leaders of these 3 faith-based organizations, and they say, oh, absolutely, we do meals, we do transportation, we do caregiver support, respite services, whatever it is that they are committed to doing. And what I would want you to do is say, okay, I've looked at our numbers, and it looks like in May we had, 17 pneumonia patients discharged from our hospital to home who lacked caregiver support. Yes, you had 100 pneumonia discharges in May, but you had 17 who were discharged home who lacked caregiver support. So that's the number you need to bring into this meeting. Say, would it be possible to serve some of those 17, those types of 17 patients? And I would bet you anything, and in my experience, the answer is yes. And so that's when you move into testing. And that's where you want to move straight from the relationship and a basic sense of what services are offered and what volume might be in play, to saying, okay, well, let's just test this process out. In July, let's make a plan that we're going to start calling you for any of our pneumonia patients who lack caregiver support that are being discharged into the community you serve, and let's just see what happens with the next 10 patients. Instead of trying to process map it and get into extended planning discussions, I really encourage you to build the relationship 10 patients at a time. How did it go for these 10 patients? What worked for us? What worked for you? What worked for the patient? What didn't work for anyone? And then modify it, try it with 10 more patients, and you get the point. So hopefully this has painted a picture on how you can really strengthen collaborations and relationships given the workforce you have, given the partners you have in the community. Really think about your high-risk pneumonia patients and where are they going, and who can you collaborate with in order to co-produce this outcome called a 30-day readmission. Ask yourself these questions. Do you have working relationships with a point person at a key set of providers or agencies that serve your high-risk patients? Do you meet regularly with them? Review data, root causes, identify opportunities to improve care for your shared patients, and test a new process with the next 10 patients who need a new service put into place for them. We are coming up to the top of our time, and I'm just going to skim here some of the chat because I wasn't following very closely. And so I would welcome any chats in, and I'll field some of the questions. So we've got a question. We're struggling to understand how we can get buy-in from leadership to create a process and hire resources to provide this kind of follow-up support to pneumonia and our other high risk of readmission patients. Any suggestions? So I would start in a couple of ways. So I selected practices to share with you today that spans the spectrum of 0 new resources, to a couple, but not a lot of new resources. And so that's kind of number one. And again, I just like to break down, what are we asking for? What are we looking for? I know none of us have time, and time is what we're calling resource, of course. But think about Joyce from Virginia. Joyce already had a job called transitional care nurse. So I would ask, do you have transitional care nurses, or even, case managers who are dedicated to, complex discharge planning, or complex patients or the like. What resource do you already have, and who is asking you to reduce readmissions for pneumonia patients? And can you do something like the Emily Skinner circle back call? Can you take the circle back call and then call 3 SNFs every Friday and go over a list of the shared patients? Even if they knew, let's just say you're the director of case management, even if they knew that if 3 of your SNFs knew that they could route questions back through you, and that you would then fulfill the function that Joyce filled in that example I shared, to delegate as you desire, but to delegate and get those questions answered and get back to the SNF. These are ways in our day-to-day work, and I know we're all promote that collaboration. Of course, everybody would love to have, right, a navigator that follows patients through the SNF and into home. And quite honestly, that is the very first and most obvious answer for any team that's in a bundle. I don't even think I've met a bundle, honestly, that doesn't have a navigator following people across the continuum. So one of the ways of engaging is to, again, connect with, what is the imperative? What is the case for change at your hospital? Is it penalties? Is it star ratings? Is it or into an accountable care organization of some sort? And if you can knit together penalties and VBP and star ratings, plus or minus bundle readiness, etc., then what I can tell you is there's no bundle that doesn't have a navigator following people for 90 days, And so the strategies are known when the accountability for outcomes is clear. So thank you so much for that question. Okay, so lots of questions about slides, and yes, Trish and the NCHA will make sure project page at the end. Let me see if there's any other questions. Okay. The last couple minutes here, with regard to market changes, I don't keep up with the latest in every state, but I know that there's not only is there a continued on Medicare, right, from CMS in terms of we've seen the penalty program, persist and stay, and now we're seeing star ratings, and I mentioned briefly the value-based payment incentive. Those two incentives, measures, are based on all-cause readmissions, and so the world is moving, founded on this, what I call it a systemness measure, which is readmissions. It really is CMS's strategic way to get hospitals to build out, right, the cross-continuum and transitional care systems that will work. And then with that, in North Carolina, only you guys will know how quickly are we moving into managed care. And I think there's been a move into managed Medicaid, et cetera. Again, I'll let you guys fill in the managed care, especially managed Medicaid. I can tell you that Medicaid from the Washington, D.C., it has just last month or two announced a new Medicaid readmission measure that Medicaid agencies are now going to need to track and measure and improve upon, which means that Medicaid agencies are going to push incentives out to their plans to do a better job on Medicaid readmission. The message that I send to leaders is, you know, we are still in the midst of a market shift here, and we know in the field it takes a solid 2 years to get a good to build the capacity and a successful system to reduce readmissions. And so if you believe that the market continues to go in the same direction with regard to expectations on performance and value, then it makes a lot of sense to start pneumonia readmissions, build the capability that you need to get success for pneumonia readmissions, so that then you can spread that model to all-cause readmissions and from Medicare, and set yourself up for success in the future market, you know, of tomorrow. So again, you know, that's not necessarily an ROI logic. It's more of a strategic direction, and you know, every leader is different in too. But I appreciate the question. Okay, well, with that, I'll turn it back over to you, Trish, to close us out.
All right, thank you so much, Dr. Boutwell. Thanks again for joining the line today. If there are any questions, feel free to reach out directly to myself or Karen or Dr. Boutwell as well. Our next call or webinar will be scheduled for August the 3rd, and we're skipping the month of July due. And so following this, you'll be getting an email related to a survey evaluation. We appreciate your feedback, as always, and input related to our future work. And then within the next 2 days, you'll be receiving an email that contains the recording from today, as well as the slide deck. So thanks again, and everyone have a great afternoon.